Well, greetings, everyone, and welcome to the EKG case for the week of August 19th, 2013. And this week, we're going to actually focus on, more than one case, but we're going to focus on a few cases of Wellens. Back on July 1st of this year, just a month and a half ago, I posted a case of the week which was focused on Wellens. And we've done Wellens before also, but that spawned a flurry of emails that I got and cases that people have sent me with some really great Wellens cases and cath reports and all kinds of great stuff. And so I've put them all together in 1 week, and we're going to go through 4 cases of Wellens that people have sent me just to really hammer home some of the interesting findings and points that we can learn from regarding Wellens. This first case, and by the way, this is going to be a challenging name pronunciation week for me. So again, please excuse my mispronunciations. I'm going to do my best. This first case was sent by Dr. Hirwa Kagabo-Dudene. And again, my apologies if I got that name slightly incorrectly. By the way, as an aside, somebody told me that on NPR radio, when people send their names in, they're told to also send in some phonetic pronunciations of how to pronounce their name on the radio. And if anybody's interested in doing that so I don't mangle your name, please do so. Tell me how to pronounce your name. But anyway, this case was sent from UAE, United Arab Emirates. And this doctor was taking care of a 43-year-old male smoker who had moderate central chest pain for about 8 or 9 hours. And so we'll start out with the 12-lead ECG. And you can see a couple of the concerns that he had underlined. In V1, there's a flip T wave in V1. Now, we'll throw some other pearls out here also, many of which you may know already, but in V1 and AVR, it is totally normal to have a flip T wave in V1. So not a big deal, okay? But it's not normal to see these biphasic T waves in V2 and V3, and the biphasic T wave pattern is the type 2 Wellens wave or Wellens pattern that we've talked about before, and that was obviously concerning. So what happened? Well, the patient had actually taken some antacids and his chest pain had improved, and so you would assume that this must be gastroesophageal reflux, right? Well, definitely not. We've talked about reflux before. I believe that reflux was a disease that was invented by plaintiff attorneys who wanted to get more money from emergency physicians and cardiologists and internists, at least in the United States. And elsewhere, I think it was a disease that was invented by the pharmaceutical industry who wanted to start selling more silly drugs for a relatively benign condition. But anyway, this is certainly not reflux, otherwise we wouldn't be talking about it. And this physician didn't think it was reflux. He repeated the 12 lead in about 90 minutes or so, and the Wellens appearance seems to be getting worse. So what did he do? He contacted his local medical team to admit, and they were not convinced, so he had to actually put some effort into convincing them that this EKG abnormality needs to be taken seriously, and eventually the troponins became positive, at which point the medical team was convinced, and they get cardiology to take this patient to the cath lab, and the patient had, no surprise, a complete occlusion in the LAD. We've typically learned that it's more of a proximal LAD occlusion, but the more and more I learn about and hear about Wellens, the more I'm seeing cases where it's not just proximal, but mid-portion of LAD as well. Anyway, the patient got a PCI and ended up doing well and was discharged asymptomatically, if that's a word. So case number 2. This is a case that Dr. Tony Arguija, who works in Long Beach, California, sent me probably about 3 years ago, and I've had this in my files for quite some time. Is a really interesting case, and finally now I have a venue to get word out about this case. So Tony was taking care of a 58-year-old guy who presented with severe chest pain, shortness of breath, sweats. I think he described it as a sledgehammer hitting him in the chest. That's how bad this chest pain was. So this is clearly a concerning story. The patient's pain's relief with nitroglycerin. So this is a slam dunk admission to the hospital, right? Well, here's the 12-lead EKG. And of course, you notice that type 2 Wellens pattern, just a little hint of it, a little hint of that biphasic pattern in V2, but very obvious V3, V4, and then flat out inverted T waves in V5 and V6. Now I want to show you the EKG interpretation. Non-specific T wave abnormality in the anterolateral leads. We've talked about this before as well. You cannot trust your computer to understand or know or detect Wellens. For some reason, the EKG computers very frequently call this a non-specific T-wave pattern, and I don't know why. People ask, well, how come they don't program Wellens into the computers? And I don't know why. But you cannot rely on your computer to pick this up. Computers will routinely, very, very often call this just non-specific T-wave abnormality, and that's completely wrong. It's not non-specific. It's actually very specific. Well, Tony knew that. He contacted his internist and cardiologist who didn't know about this. And they said that they just wanted to do a stress test and then discharge this guy home. He knew about the literature saying that if you take a patient with Wellens, in other words, a proximal LAD obstruction, and you put them on a treadmill, they're going to have a bad outcome. And he warned them. They didn't listen. They ended up putting this guy on the treadmill for an exercise stress echo, and the test turned positive. He developed ST segment elevation, and then the test became even more positive when he started doing this on his rhythm strip. The patient went into ventricular fibrillation, collapsed. They had to run a code in the hospital for this guy. Fortunately, they ended up getting the patient back, and he ended up going for PCI after defibrillation and everything. And he had a big LAD occlusion. He was successfully stented, and I think the patient fortunately ended up doing okay. But it was a nice learning session, hopefully permanent learning for the inpatient folks who put this guy on a treadmill. Again, the literature supports the contention that when you see that Wellens patient, they need invasive management, but stress testing on a treadmill is not a good idea. I don't know about non-exercise stress tests, but in terms of exercise stress tests, it's a really bad idea to take a patient with a probable proximal LAD occlusion and put them on a treadmill because this, by the way, has not been published. And so who knows how many unpublished cases there are of patients having cardiac arrests with this Wellens. But there are also published reports of patients who had Wellens who got put on a treadmill and dropped dead or had really bad outcomes. So do not put these patients on a treadmill. Okay, case number 3. This comes to us from Malaysia. Dr. Kianseng Ng is an internist working in Malaysia, and he does a lot of teaching at his local university. And this was not his case, but it was a case that he spent some time teaching about, and he actually sent me some very nice slides from his presentation. And I'm going to borrow some of the images that he used. It was a 48-year-old man that came in with severe low chest pain and epigastric pain and distension for 2 days. This guy's got no history of reflux, but of course, because it's improving with belching and it's epigastric in location, he says to the physician, I think it's reflux, right? Be very careful about ever calling something new reflux. Especially in somebody with cardiac risk factors. Apparently, this guy had a big-time cardiac risk factor, and he smoked, quote, smoke like a chimney, unquote. Anyway, he gets an initial EKG. There's no others for comparison, but the initial one's done around 11:15 or so, and here's that initial 12-lead EKG. Now, this EKG machine runs it in a slightly different pattern, so this is lead 1, that's lead 2, that's lead 3, that's AVR, that's AVL, that's AVF. Let me revise that. That's AVF. And then there is a V1, V2, V3, V4, V5, and V6. Now, there's nothing really jumping out about Wellens here. Maybe just a little hint of a biphasic pattern right there in V4, and then some kind of non-specific, I would say non-specific junk in V5 and V6. But it's a little hint of something. And I'm not sure that the treating physician made a big deal about the EKG, but he appropriately made a big deal about this guy with a big smoking history trying to self-diagnose with first-time reflux. Be very careful about that. So what this physician decided to do was just watch the patient for a little while, repeat the 12-lead a few hours later, and he's now asymptomatic. I guess the first EKG was done with some of this refluxy symptoms. Now the guy is completely asymptomatic when the repeat 12-lead ECG is done, and now you take a look and it's really jumping out at you. V2, really in V3, V4, V5, and V6. And Dr. Ng actually put these two images together. And so this was the initial ECG at the top with some mild symptoms, and this is a few hours later. Serial EKG is a really great idea, right? Get those serial EKGs or serial ECGs, and you'll be surprised how often those serial ECGs end up being very diagnostic. And in this case, take a look at what happened here. V2, just a little hint of Wellens, but clearly becomes Wellens or Wellenoid in V3, V4, and then flat out just inverted in V5 and V6. So that was a big time change. Dr. Ng actually sent me the cath images, which is really great. So here's the before and here's the after. You can take a look at that LAD and how occluded that LAD was. And that's what you expect to see with Wellens, including in the asymptomatic state. So another great case, and fortunately that patient ended up doing okay. And case number 4 is sent by a French cardiologist by the name of Dr. Paul Gassibi. And he was kind enough to send some cath images as well that I'll show you in just a moment. This is a 49-year-old woman who's got diabetes and hypertension who is sent to his office for just a routine checkup, routine cardiac checkup. She's apparently got no prior cardiac history. And, you know, if you really draw some symptoms out of her, maybe she's had occasional tingling on the left side of her chest that she actually was just attributing to maybe her bra straps, according to Dr. Gassibi. But really unremarkable history of present illness. She's asymptomatic, so he just gets a routine 12-lead EKG, probably not expecting to see much of anything. But sure enough, he does see something. Now, again, remember she's asymptomatic, and she's got biphasic T waves in V2, V3, and maybe out here, well, definitely in V4, and then inverted out there in V5 and V6. Okay, there's also just a little bit of ST elevation that I know some people will email about if I don't mention, but you can sometimes have isolated ST elevation in V2, and if you don't see concerning ST elevation in V1 or V3, just isolated in one lead, you're not going to make a big deal about. And then on top of that, she's asymptomatic, so you're probably not going to make much of that. She's definitely got poor R wave progression. There's just a tiny, tiny R wave in V3, and maybe even Q waves in V1 or V2. Maybe she's had a previous anteroseptal MI then. So because of that concern, he ended up getting an echo on the patient because of that concern of possible old anteroseptal MI. The echo was fairly unremarkable. At most, just a small area of hypokinesia at the apex only. It really was not significant for a previous anteroseptal MI. But because of those Wellens waves that he saw in those leads that we pointed out, he sent this patient for a cath, and at cath, what did they find? Triple vessel disease, including a critical LAD stenosis. That EKG predicted it, right? And here's some images. I think I've got some images here from the actual cath report. And whoop, went too far. There we go. There's the cath, and you can see the before. That's French for before. I had to ask my son, who's taking French in school. That's before, and this is after. And you can see that LAD, how they ended up seeing the occlusion, and they stented it open. And Dr. Gassibi sent me something that I've never gotten before. He sent me the post-cath 12-lead EKG, which now shows resolution of Wellens. So it's a great example of how the tight occlusion in the LAD is correlated with those biphasic T waves, and once you get rid of the occlusion in the LAD, the biphasic T wave pattern goes away. It's a very, very nice example of that. And if you just scroll back a little bit and take a look at the pre-cath compared to the post-cath 12-lead EKG, you can see that very, very nicely. And this patient ended up doing well. Okay, so just some quick take-home points. Once again, unrelated to Wellens, we always try to emphasize the importance of getting serial EKGs, and you can see in a couple of these cases how getting serial EKGs was helpful, especially even in the asymptomatic state. Sometimes your repeat EKG, when the patient becomes asymptomatic, can be very revealing. Secondly, don't rely on your computer interpretations for the 100th time probably on these videos. You cannot rely on your computer to tell you the proper diagnosis. And especially with Wellens, your computer will not detect or will not diagnose that Wellens type 2 or the biphasic type of Wellens waves. It has a tendency to call those non-specific T-wave abnormality, and it's not non-specific. If you call it non-specific, you can really be missing a critical LAD occlusion. Number 3, beware Wellens waves. Get familiar with Wellens waves. You've got to be on the lookout for this, all right? And if you want more information about Wellens, just scroll back to July 1st, 2013, where we spent a bit more time talking about Wellens. And then finally, just a reminder, when you see Wellens waves and you're worried about anybody who's got a possible critical occlusion in the proximal LAD, do not put that person on a treadmill. The non-exercise stress testing, well, those might be safe. I don't know. But the exercise stress testing, there are enough case reports out there, and we're hearing about these type of things to say that it is not a safe thing to do. And even if you look at the stress testing guidelines, they will say that if you are suspecting a person to have a critical proximal LAD occlusion, you don't put them on a treadmill. All right, so that's kind of common sense. All right, so once again, my thanks to everybody who has sent these cases, these 4 folks who have sent very nice Wellens cases to share with everybody else out there. Really appreciate it. I think we can continue learning more and more about some of these EKG abnormalities, even in asymptomatic patients, and be on the lookout for Wellens. So I hope that was helpful, and I look forward to talking to all of you next week. Bye for now.